Thank you very much, Kieran, and thank you very much for inviting us to the conference this afternoon. I'm going to start off. My name is Mary Keogh. Up until the last 4 months, actually, I worked in the HSE. I worked in the States for 20 years and then worked in the HSE for the last 10 years. So I suppose I was on the other side of the fence, the side where I was the one dreading the thought of HICWA walking in the door. And when I took up this post a couple of months ago, one of my good friends who's a GP said, "So Mary, you've gone to the dark side," was the first thing. And the second thing was, "For God's sakes, please just keep them away from my door." So I just want to start off by saying I'm from a brand new directorate in HICWA, and that's what I'm going to talk a little bit about, because what we want to do when you talk about standards, it's very much based on all the stuff that people have talked about here this morning. What we're trying to do is improve care, not have a stick to beat people with. And I think that was would have been my feelings around it sometimes when I was on the other side of it over the past 10 years. So we have a brand new directorate now in HICWA. There are actually 4 directorates in HICWA. There are, and I'll start from the bottom up because you may be familiar with some of them. The Health Technology Assessment Directorate look at things like cervical screening, things like deep brain stimulation for Parkinson's disease, and they're informing policy. So they do a kind of a value for money and a clinical effectiveness assessment to see, is it a good idea to bring something like this in on a national scale? But they also then will help the likes of a primary care team to do a mini HTA around something that they wanted to improve in their service or something that they want to bring in, and they'll help them to do the HTA around that. Health information then, as you know, is a very, very critical part of the way we manage healthcare, because everything is around healthcare information, and the vast majority of times when something goes wrong for us, it's because the correct information didn't get to the correct person at the correct time in order to make the correct diagnosis or the correct decision. So that's very much about data quality, about data protection, about they're really trying to work with the department in getting this unique identifier and the health information bill put through the DAL and everything. So that's the health information side. The regulation side is the side that we're all aware of, except that it's now, after coming together in a different way, there's a new director of regulation. His name is Phelim Quinn. He only started 2 weeks ago. He would have been the director of regulation up in Northern Ireland for RICWA, and has a different approach to regulation than what has been here so far. And I'm going to talk about that in just a second, this idea of responsive regulation, because we don't want a situation where you're just regulating to judge and to shut something down, because all you end up getting then is you kind of get the absolute minimum standard. We want to be regulating to improve, even in the current environment. And in order to do that, you have to help people. And that is where the Safety and Quality Improvement Directorate comes into play. So when I had an opportunity when I saw this role be advertised, I thought, my God, this is fantastic. Even to think that HIC was going to start doing this is a really positive sign. So the functions of, and by the way, Safety Quality Improvement Directorate rolls lovely into a little acronym called SQUID. So it's very easy to remember. You just have to think of that little whatever you call it, creature with all these helping tentacles, helping hands coming out of it. So that's what I hope you take away from today when we talk about HICWA and SQUID. So it's about setting standards. So there are standards that have been set already in the care of the older person services. There were standards set for disability services, and they're going to start inspections on that in the Regulation Directorate in July of this next year. There are child protection standards, and they're going to be monitoring those as well. And then there are healthcare association infections that have been there for a couple of years, and they are being monitored as we speak. Actually, there are inspections going on as we speak. The next set of standards then, we have the national standards for safer, better healthcare. And I'm going to talk a small little bit about those, but the idea is that they're principle-based standards. So the idea is that they're very broad, and the whole idea around that is to try to not stifle innovation. One of the horrible things that happens sometimes is if you have a real checklist approach to standards, people end up the week before the visit getting all those little things in place, and they make sure that their policies and procedures are all done up and they're put on a shelf, and inspectors come in, and then Monday there's a huge sigh of relief and, okay, now let's just get back to our ordinary business now. And nothing is embedded into the system. So what we're going to do in SQUID is we have a program that we're about to roll out in January where we're going to develop, we're working in collaboration with a group in the States called IHI, Institute for Healthcare Improvement, and we're going to provide education free of charge because we've purchased the licenses with the IHI, and we are going to now provide education. We're going to start by providing it in 4 acute hospitals in Ireland, adult hospitals, 4 primary care teams in Ireland, and that is for the next year. But then in the middle of the year, we will also start in the care of the older person sector, and we're going to deliver training in nursing homes as well. And this will be a kind of a rolling project until such time as I've worked myself out of a job, in that we want to get to a point where people are trained up. And you might ask, but you know, what is this kind of training about? Well, I'm a nurse by background. I trained many moons ago, but unfortunately most of the other people that are delivering service also were trained many moons ago. So we have a group, especially a group of management and middle management in the healthcare service that would have gotten an education in their professional area, whether it be medicine or nursing or physio or pharmacy, that did not include anything around quality improvement science. We did not learn how to measure ourselves. We didn't learn that we needed to measure ourselves. We didn't learn what kind of data we should be measuring. We didn't learn how to analyse data. We didn't learn how to evaluate it and how to display it to somebody. And yet, all that happened, didn't happen rather. We were brought through school, we didn't learn how to do those things, and yet there is now an environment where standards have been developed, and all of a sudden people are saying, and we heard it all morning, we need to give people the data. And what people would say to me in my previous role in the HSE was, how in God's name do I provide the data? What's the data supposed to look like? What is a continuous quality improvement programme supposed to look like? What am I supposed to be improving? So that's what we're going to do. We're going to give education in the very basic quality improvement methodologies. It's an online programme. It's over 16 modules. And we're going to not only, we will bring people in, we will go out to people because of all the travel restrictions right now. We will go into teams, we will get people registered with the IHI online programme. We will support them through it with weekly teleconferences and monthly meetings, and we will get them through the end of the programme. And the reason we're doing that is not because we're just a really lovely group of people who want to do this for everybody, but if we're going to try to improve anything in healthcare, and if we're going to be going out and asking people to meet standards, we need to give them the basic tools that they need to understand how they can actually show the evidence of what they're doing. You can hear it this morning, you could see it on the posters. There's amazingly innovative work being done all over the country. The problem is that a lot of times we don't know how to actually show that to somebody else and provide the evidence of it. And I think it came out even clearly today when somebody was questioning the data, the numbers that are coming out. We're not even measuring appropriately. We don't even know what we should be measuring. So that's the type of thing that we need to start doing. So that's the promoting capacity and capability, and I spent so long on that because that's the fundamentals. That's what we're going to focus on for the next year, 2 years, 3 years. As part of that, we are going to roll out a national patient safety programme next year, and that is going to be done as an action learning component of the training. So those teams that are participating in the training are going to work on a medication reconciliation project. Now, for those of you that are sitting down there thinking, oh, sweet Jesus, here's HICWA now doing this. HSE are doing a whole other bunch of stuff. Patient Safety Unit over in the Department of Health are doing a whole other bunch of stuff. And there's God knows how many other different institutions around the country all coming out with these great, grand ideas for how we're going to improve the quality of care. The good news is we're all talking to each other. And that is a new thing. So we're all collaborating, we're all talking, we're all in it together. So the medication reconciliation is going to be led by ourselves in conjunction with Tim Delaney in the HSE, in conjunction with Marita Kinsella in the Department of Health, and in conjunction with Professor Mike Scott up in Northern Ireland, who's done a lot of this work. And we're going to have an advisory board that is going to consist of nurses, pharmacists, GP, we're going to have GP representation, because one of the things that I learned very early on in this job, I met a certain gentleman to my right, and one of the things that he would have said to me was, involve us. For God's sakes, just involve us. Get us on board, talk to us, tell us what you're doing, and ask us to be involved in that. And you can thank Kieran over there in the corner for that. And I have never forgotten it. So it's chief on our list of things that we're going to keep doing. Supporting a culture of patient safety then will come as a result of all this, because the people will have the training that they need and will be supporting the culture of patient safety. I'm not going to go through some of these things, because the Don't Waste a Good Crisis has already been said now a couple of times. This is the kind of environment that we need in order to be able to roll out any kind of quality improvements. And one of the things, sometimes I get frustrated with this whole, even the talk around quality improvement, because it's such a nebulous term. It's surrounded with this awful jargon that people have put together when they wrote their master's or their PhD or whatever they did to invent new words around quality improvement. I always keep one thing in my mind. And a bit like Jennifer earlier, I do get a bit emotional about it at times, because what I keep in my mind is a man that I love really, really dearly, and it's my dad. My dad is 83, he's got Parkinson's, he's a patient. You all have one of those. You all have a mother, you all have a daughter, a son, a niece or a nephew. They're the patients. Patient-centred care are us and our families. So it's personal to us. This is not something that's a nebulous concept. These are our family members. And I think if we can always just keep that at the core of everything that we do, the agendas and the egos and the politics and everything else needs to just be thrust aside, so that we can actually get the job done for the people that we love. Dad has cataracts now. Brought him to his GP a couple of weeks ago. Wonderful GP. Got a letter sent off over to the hospital where he needs to be cared for. And he got a fantastic letter in the post about a week later saying, "Dear Mr. Keogh, please come for your outpatient appointment on the 20th of August 2014. My father said to me, "Mary, I'll be dead or blind." It's not funny. This is my father. I don't want him dead or blind in 2014. I want him to be able to go into a place where he can get his cataracts taken care of. And I'm hearing people this morning saying that these are the types of things we should be looking at doing in primary care centres. Okay, thanks, Kieran. So let's do it. Let's find a way to make these things work, but we have to do it in a way that we are all talking to each other. And for those of you that are petrified at the thought of HICWA walking in the door, we don't need to be petrified at the thought of HICWA walking in the door, because HICWA, the squid side of HICWA, is now going to help people. It's going to give people the tools. It's going to roll out the quality improvement projects. It's going to help people to be able to do the work that needs to be done in order to meet the standards. So it's not going to be the stick to beat you with. And I'm going to finish up on just something here now, if I can click fast enough. Sorry, Kieran, I'm getting there. Right. This is what I want to get to. This is the old way of regulation. This is the regulatory pyramid, Jeffrey Braithwaite's regulatory pyramid. And so you went in and you identified the problems and you told people about the problems and you sent them a letter saying, you know, fix that, or we're going to come in and we're going to do something else. And then you sent another letter, fix that, or we're going to really come in and do something else. Next one was, we're going to close you down. Next one was the High Court. That's regulatory pyramid of regulation. This is what we're doing now. We're going to educate and persuade around a strength. But to do that, I need to be able to go out and convince the system that I used to work in and convince the likes of yourselves that are saying, please keep HICWA away from my door, to actually say, Mary, will you come in? Will you come in? And will you help us? Because we actually want to do a few improvements, but we're not quite sure how to do them. And will you help us to do that? So that's the message I really want to get out today more than anything else. You probably are aware of the standards. The good news is that the GP practices are not going to be visited any time in the very near future, but they will be coming on board. But you'll be coming on board because by the time you come on board, if you take up this model that we're offering you, you're going to be saying, hello, I live in Kerry. I'm down in Kerry, will you please come down here first, because we'd actually love to show you what we're doing. And that's where we need to get to. And every one of us should be feeling that way, because again, these are our families that are our patients. So these are basically just the standards. You've probably seen that model. If you haven't, I'm more than happy to come down to your practices and talk to you about this. The most important thing is this part here, working together. One of the big things, and I'm going to say it and then I am going to shut up, One key barrier I have had, and for me it's the elephant in the room. When I was working with the HSE, I tried on multiple occasions to get GPs onto certain things. The biggest barrier is that I come here today as a member of HICWA and I'm paid to be here today. You have come here and you've left your practice here today and you've had to pay to bring in a locum, or you've had to pay to bring in somebody. And that is what I see, and I'd say to Kieran as well, that is what I see as the greatest barrier to me trying to engage with GPs, because I can't turn around to Tracy Cooper and say, Tracy, I really want to get GPs on board. Can we work something out with them and we can pay them for a locum or for something? Now, I'm going to work on that, to be honest with you, but I can't guarantee that here today. What I can do instead is I can say, I'll come to you and I'll work with you and I'll sit down with you to engage with you. But I can't do it, I can't, put somebody in your place when you're here. But it is a barrier for us, and I'm not sure if it's one that you recognise or that I'm sure ICGP has recognised in the past. It becomes difficult for us. We definitely want to engage, but it just makes it that much more difficult because we understand that for you it's a day's work that you're not paid for. So I'm going to leave it with there. I have written on there clinical engagement as a priority. It is a priority, and that is including GPs. And I will never forget the way Kieran said that to me at the beginning. And I absolute vow to you that that's what we're going to do. I need your help to do it. So I'm going to leave cards up on the table afterwards for anybody if they want my email address. So thank you very much for the opportunity.